Hi, everyone. Welcome to our Facebook April case study. My name is Dr. Kelly Ruef. I'm a clinical consultant for Precision Analytical, and we have a pretty exciting case study this month. It's all about a postmenopausal woman with a thick endometrial stripe. So let's dive in. So this is me, and here's my Instagram. It's Dr. Kelly Ruef. The learning objectives. So we're going to learn about how endometrial thickness relates to cancer risk in postmenopausal women. We're going to discuss obesity's impact on uterine health, and then we're going to dive into our case study. All right, so just imagine you are a postmenopausal woman and your doctor, this doctor right here, has just told you that you have a thick endometrium on a transvaginal ultrasound. So what now? What happens? What do you do? Well, it turns out that the next steps depend on how thick the endometrial stripe is, so how thick the endometrium is, and also depends on if you have abnormal uterine bleeding. So, for example, let's say you do have abnormal uterine bleeding. So, let's say you are bleeding and they find that your endometrium is 7 millimeters. So in that case, if the endometrium is over 4 millimeters and you have bleeding, they want to do further workup. And that's usually an endometrial biopsy. But if you don't have abnormal uterine bleeding, so you're not bleeding, your endometrium has to be above 11 millimeters in order to do the endometrial biopsy. And about 5 to 20% of patients that are diagnosed with endometrial cancer never had bleeding. So that's really good to keep in mind. A lot of times we think that endometrial cancer always presents with vaginal bleeding, but not always. I really liked this study. It basically says that if you're a postmenopausal woman with uterine bleeding and your endometrial thickness is above 11 millimeters, you have a similar risk for endometrial cancer than if you're a menopausal woman without uterine bleeding with a thickness of greater than 5 millimeters. So very similar risks here. Okay, how does obesity affect uterine health? So here's a study from 2016, and they found that women who were obese, so when their BMI was greater than 30 but less than 35, that was associated with a 2.6-fold increase in endometrial cancer risk. And if they were severely obese, so their BMI was above 35, that was associated with a 4.7-fold increase. So that's quite a bit of an increase for risk for endometrial cancer. And this study from 2016 was interesting because it did say that obesity is now recognized as an independent risk factor for endometrial cancer. So that is huge to know, very important. So why would obesity increase risk for endometrial cancer? Um, they're basically thinking it's because usually when women are very overweight, all that extra fat tissue will be converting, it'll be aromatizing androgens over to estrogen. So you always hear about people saying, oh, fat tissue makes estrogen, and it's actually converting it from androgens. So when you're obese, you tend to have higher serum estrogen levels, and we know that serum acts on that uterine tissue and causes growth. And this is a study that just says, we should investigate oral micronized progesterone and vaginal micronized progesterone to prevent endometrial hyperplasia and cancer. Um, remember, progesterone balances estrogen's effects in the uterus. And remember, micronized progesterone is bioidentical. Here are some studies showing that 200 milligrams oral micronized progesterone protects the endometrium when women are also taking estrogen. And this information comes from Dr. Doreen Saltiel's webinar on menopausal hormone therapy. I highly recommend this webinar. She did a great job And the link is below. You can see if you type that in to Google, you can find it. Okay, so let's jump into our case study. We're talking about a postmenopausal woman. She's in her 60s, and she was diagnosed with a thick endometrial stripe. So her BMI is 40, so that would put her at a 4.7-fold increased risk for endometrial cancer. She's been postmenopausal for 10 years. She's, a little fatigued in the afternoon, and she's taking some mushrooms, a B complex, D3, lysine, and taurine. And she's hormone naive. So by that, I mean she's never taken hormones, no hormones at all. No estrogen, no progesterone, no testosterone. So if we look at her Dutch complete here, we can see this is the summary page. This is page 1. And on page 1, we have kind of some of more of the important markers that practitioners like to see side by side. So here you can see her estradiol and her progesterone right next to each other. And remember, in between these two stars for the estrogen and the progesterone, that's the luteal range. So that's for a premenopausal cycling woman. And this little purple band, that's the postmenopausal range. So we would expect, she's postmenopausal woman, we would expect her estrogen and her progesterone to both be pointing in these little purple bands here. But look at this, her estrogen is in the luteal range. So it's way higher than what I would expect for a menopausal woman. But the progesterone is right where I would expect for a menopausal woman. Down here we can see a little bit about her cortisol, but we'll get into that in more detail soon. So this is page 3 of a Dutch Plus report, and it gives more of a more detailed look at the sex hormones. On the top right, we have these progesterone metabolites. And remember, urinary progesterone metabolites, they strongly correlate with serum progesterone when progesterone is not being supplemented. And so if you look at this top marker here, this is the weighted average of the two progesterone metabolites that we measure. So this is what her progesterone looks like in the serum. And this is pointing in the postmenopausal range. This would be close to about 1 nanogram per mil in the serum, so low. And then down here we have the estrogens. Remember, page 1 only had the estradiol, which is her most potent estrogen. But page 3 also has the estrone and the estriol. We can see all 3 of these are in that luteal range. And urinary estradiol strongly correlates with serum. So an estradiol of 2.5 in the urine, that's similar to like 150 picograms per mil in the serum. So that would definitely be high for a postmenopausal woman. And if you zoom in, we can see that her estrogen is in the luteal range, but her progesterone is very low. So they are not balanced. She's got too much estrogen for the amount of progesterone she has. She's estrogen dominant, you could say. So down here, we can see how she's metabolizing her estrogens. Whenever I see a woman who's got excess estrogen, I like to look at how she's metabolizing it. And these 3 metabolites here, these are the phase 1 metabolites. And remember, phase 1 metabolites tend to be reactive, tend to cause oxidative damage in the body. So we don't want them to be in phase 1 for too long. We want them to move over to phase 2, where they turn into these more water-soluble, stable compounds that are readily excreted from the body. So here are her 3 reactive phase 1 metabolites. And I like that all of these dials are pointing lower than her parent estrogen here, than her estrone. That's a good sign. I also like that her 4OH percentage is 9.2%. So it's getting kind of towards the higher side. We want it between 7.5 and 11%, but it's still within range. So that is great. Remember, the 4OH metabolites can become reactive quinones, and they can attach to DNA and break off, and attach to DNA again and break off, and attach to DNA. So they can cause a lot of DNA damage and increase risk for endometrial carcinoma, for breast cancer. So if you look back on page 2, You'll notice that we're also testing the estradiol estrogen metabolites. Remember on page 1, these are the estrone, the E1 metabolites. And so we've got the 4-hydroxy estradiol on page 2. I also like to look at this one. It's on the high end of the luteal range. So I don't like seeing that. High end of luteal range, that makes me a little worried about cancer. So phase 2, one component of phase 2 is methylation. And here we can see her methylation activity. See how this dial is pointing towards the left? It's low. So her phase 2, her methylation is slow, at least for this estrogen pathway on this day. And that could be a reason why that 4-OH is getting on the high end, because the 4-OH and the 2-OH, those metabolites get methylated in phase 2. So if you've got poor methylation, those 2-OH metabolites, those 4-OH metabolites are going to build up and back up in the body because they're not being moved over into phase 2. So that can be problematic. And of course, on the top left, we have her androgen metabolites. And below that, we have these age-dependent ranges. So always look at the age-dependent ranges and kind of correlate it to these values. Because if you just look at the dials, they're all green. You might say, oh, they look good. Green is good. But actually, if you look up closer and you compare it to where she should be for her age or where we would expect her to be for her age, all of them are above range. So I automatically know, wow, she's got robust androgens for her age. And if you go back to page 2, we have more androgen metabolites that we measure that are not on page 3. So go back to page 2. Remember, 5-alpha DHT is our most potent androgen. It's kind of like the active form of testosterone. It's 3 times more androgenic than testosterone. So I like to look at the 5-alpha DHT. Look at hers. Way above range, even high for a premenopausal woman. And I also like to look at 5-alpha androstenediol because there's some research showing that 5-alpha androstenediol might actually be a better indicator of DHT levels in the tissues than actual DHT itself in the serum or possibly the urine. So 5-alpha androstenediol also above range. That's making me think, okay, she's got some robust androgens. She's got some higher DHT in the tissues. So where are androgens produced in women? I will say this slide is for premenopausal women. In postmenopausal women, their androgens tend to come more from the adrenals. But you can see in a premenopausal woman, a younger cycling woman, her adrenals are making the majority of her androgens. So in women, the adrenals play a huge role in androgen production. So she's got higher androgens and she's overweight. She's got more fat tissue. So higher androgens with more fat tissue to aromatize it to estrogen usually results in higher estrogen levels. So now she has all this estrogen in her serum floating around, acting on her uterine tissue, causing that endometrium to thicken because she doesn't have progesterone around to oppose that effect. So of course her endometrium is going to thicken. So she's got high androgens. Why? We know ovarian output and adrenal output. So these two can produce androgens. Stress, of course, stress can increase androgens in the body, high body fat percentage, insulin dysregulation, low sex hormone binding globulin. Remember, if you have less binding globulin around, you're going to have more free hormone, more free testosterone floating around. So it'll increase your free androgens. And then, of course, we have the non-classical congenital adrenal hyperplasia, PCOS, thyroid issues. Definitely want to check the thyroid. HRT transference. So does she have a partner who's using testosterone cream, for example? Is she taking testosterone, supplementation? She's not. And then, of course, suboptimal clearance. If she's not clearing out her androgens effectively, if she's not processing them effectively, they're going to build up in the system. And beta glucuronidase, a lot of times we test that in the stool, and a lot of times if it's elevated, we think about how it can take estrogens that are in the stool, that are in their, they're on their way out of the body. It takes those estrogens and causes them to be reabsorbed back into circulation. So we usually think about beta glucuronidase in high estrogen, but beta glucuronidase can also do the same to androgens like testosterone. Some testosterone is processed through glucuronidation in the liver. So we have some glucuronidated testosterone in the stool. And if beta glucuronidase is elevated, it's going to cause that testosterone to be reabsorbed back into the body. So we might also want to do a stool test. So here I listed some things, some contributors or things that are correlated with low sex hormone binding globulin. And we see it often with obesity, which she has, high insulin, metabolic disorder, fatty liver, thyroid issues, PCOS. So something to look out for. And it's interesting because ground flax seeds, if you take a couple tablespoons of these a day, it's known to help increase sex hormone binding globulin. So you have more of that binding globulin to bind up hormone. So there's less in the free form acting on the tissues. So let's look at her adrenals. Whenever I see a woman with robust androgens, especially in menopause, you want to look at the adrenals. Because remember, the adrenals make a lot of our androgens. And we can see the total DHEA production here. Remember, we're adding up three markers, DHEAS and the two downstream DHEA metabolites, which are etiocalanolone and androsterone. So those three together come out to be 1,669 for her, and that's above range for her age. So she's got some high DHEA. Now we look at metabolized cortisol. So remember, metabolized cortisol is looking at THF and THE in the urine. And remember, when the body's done using free cortisol and free cortisone, it doesn't want it anymore, wants to get rid of it. It metabolizes them to THF and THE. Those are cortisol metabolites. Those metabolites cannot become active again. They're inactive, they're on their way out of the body, they go out in the urine, and this is where we measure them. And so this can give you a kind of an idea of overall cortisol production or overall adrenal output. And hers are above range. So she's got some high cortisol production, some high adrenal output. And when you've got high adrenal output, you tend to have higher androgens also. Not always, but you tend to see higher androgens because the adrenals make a lot of androgens, right? So this little fan gauge tells you systemically, is there more active cortisol around or more inactive cortisone? She's very balanced between the two. With obesity, sometimes you tend to see more of a preference of cortisol, the active form. And if we look at her cortisol in the saliva, in the free form, we can see she's got low cortisol. Remember the gray shaded region right here? That is the reference range, and the blue line is her result. So she's got a low cortisol awakening response, just the first 3 points here, and she's got low cortisol. And remember, saliva-free cortisol represents circulating free cortisol. So she has low cortisol in circulation. And we see this with obesity. The older studies were mixed, but the newer studies that are coming out are showing that as adiposity increases, as people get more and more overweight, we tend to see their free cortisol decline. So this brings up the questions. A lot of people are so confused. Okay, so let me get this straight. Metabolized cortisol is high, so they're making a lot of cortisol, but their cortisol is low. I don't get it. So how can this be? And the answer is basically we're just increasing the rate of cortisol clearance from circulation. So we're taking that free cortisol in circulation, we're clearing it out of circulation quickly. And what contributes to this increased rate of cortisol clearance from circulation? So it turns out one factor is obesity. So the fat tissue actually can steal cortisol from circulation because it needs to use cortisol for its own metabolic needs. So with the fat tissue stealing cortisol from circulation, you're going to see low cortisol in circulation. It's all in the fat tissue, but the fat tissue is using it and metabolizing it. So you still see high metabolized cortisol. You can also see this pattern with hyperthyroidism. So hyperthyroidism tends to clear out cortisol more quickly. And the way I remember that is you wouldn't want high cortisol in circulation and hyperthyroidism. You'd probably be so anxious, you'd have heart palpitations, your bone health would be terrible. So when you have hyperthyroidism, your body tends to lower free cortisol and chronic stress. So again, high adrenal output can contribute to elevated androgen production. So this is probably something that we would want to work on. And then if you look at her organic acids, you can see her vitamin B12 marker, her methylmalonate is above range, and that means she's deficient in B12. And I love this marker. I love methylmalonate in the serum or the urine. It's a better marker than serum B12. And it's showing she's deficient. And if you look down below here, I've got some studies, one from 2019 showing that serum B12 is lower among obese adults compared to non-obese adults. Her melatonin is low. Look at see it's below range at 6.6, and low melatonin is associated with obesity. So let's talk a little bit about melatonin and obesity. This study from 2017 shows that melatonin deficiency has been demonstrated to correlate with obesity. And we know that melatonin is necessary for the production and the action of insulin. So melatonin can help regulate blood sugars to some degree. So if there's an issue with melatonin, perhaps you can't regulate your blood sugars as well. And that could contribute to obesity. And I liked this study. They're talking about how we're contaminating, I like how they say contaminating our normal period of darkness with artificial light. So all this artificial light, looking at our phones, our tablets, staying up late, watching TV, that's messing with our melatonin. And perhaps just all this extra light is contributing to the obesity problem that we have because it's affecting our melatonin. And this study, they talked about obese individuals who were trying to lose weight and they were using a calorie restricted diet. And when they added on 10 milligrams of oral melatonin per day, they found that these individuals lost more weight. So they think it helped with the antioxidant defense and it upregulated or it regulated adipokine. I can never say this word. Adipokine secretion. So those are like leptin. So kind of helps to regulate things that are involved with the fat tissue and the blood sugars. Okay, so here's the summary of the findings that we found for our postmenopausal woman in her 60s. So her estrogen is way above the postmenopausal range. It's in that luteal range. But her progesterone is low. It's in that postmenopausal range. So we have estrogen excess here, estrogen dominance. We don't have enough progesterone around to protect her uterus from all that estrogen. We found low methylation activity for the estrogens. And of course, we need methylation to help clear out those estrogens. We also need B12 to support methylation. And remember, B12, she was deficient in B12. So remember, if we go back to biochemistry, homocysteine gets converted to methionine in the methylation cycle, and you need B12 and folate for that. Also choline. Choline is another way you can turn homocysteine into methionine, but eventually methionine becomes SAMe, and SAMe is that methyl donor. So SAMe goes over to the enzyme COMT, and says, "Hey COMT, here's a methyl group. You can have it." And COMT says, "Thank you. I'm going to take this methyl group and I'm going to methylate something. I'm going to methylate the 4-OH estrogen catechol. I'm going to methylate the 2-OH estrogen catechol." So B12, very important. So if we give her B12, it might help her methylate. It might help her clear out her estrogens. And she's got elevated androgens. So androgens aromatized in fat tissue, probably contributing to her elevated estrogens, definitely. She has high cortisol output from the adrenals, probably also causing high output of androgens from the adrenals. She's got that low free cortisol in circulation, that low cortisol awakening response, no wonder she's tired, that B12 deficiency, and low melatonin. So here are some additional labs, and a lot of these are in the blood. So, the CBC, the CMP. The CMP is going to have the fasting glucose, but I'd also want to do like the hemoglobin A1C, fasting insulin to get a better idea of her blood sugars. Also, a lipid panel, ApoB, LPA, CRP, high sensitivity to look at some inflammation, CIMT, which is carotid intima media thickness. So that is an ultrasound that looks at the carotid artery, and it's just seeing how thick it is. So it can kind of give you an idea of plaque formation, calcifications. And I want to do this additional cardiovascular workup because of her, well, the obesity, the possible blood sugar issues, the possible ongoing inflammation, but also she's got that low cortisol awakening response. And with a low cortisol awakening response, you tend to see that correlating with cardiovascular issues. We also want to look at her thyroid. Remember, the thyroid can affect um, fat deposition, can affect adrenal health, sex hormone binding globulins. We definitely want to look into that. And I might want to see her vitamin D, her iron, her ferritin, and of course, continue to monitor that endometrial thickness. Some additional labs you could think about, for example, genetic testing. There's a lab out there called MaxGen Labs, and they have a genetic test called the Works. So we might want to see how are her genetics playing a role in her metabolism? How are her genetics going to affect how she's able to lose weight? What exercises are best for weight loss? How are her genetics going to affect inflammation, her lipids, her vitamin deficiencies, her sleep issues, cardiovascular health? So that might be interesting to add on. All right, so we have come to the sample treatment plan. So for example, what we could do, and this might change depending on the labs we get back. If we see she's hypothyroid, we might add on some thyroid. But we might want to give progesterone, 200 milligrams by mouth at bedtime. Remember, we usually take it at bedtime because progesterone tends to make women sleepy, calm. It acts on the GABA receptors in the brain, so it really can help with sleep. And we want to use that progesterone to just help oppose all of the estrogenic effects in the uterus. We're going to be using that while we're working on regulating the blood sugars, while we're working on weight loss, for example. We're going to add on the 10 milligrams of melatonin at bedtime because she was low in melatonin, and we know melatonin can help regulate insulin and maybe help with the blood sugars. There are some people with certain genetics where melatonin actually doesn't get cleared out very well, and it can have a negative effect on blood sugar. So maybe another reason to check genetics. We're going to add on sublingual B12, might help with that methylation. And I like doing sublingual B12 in older individuals because their stomach acid tends to decline as they get older. And we need stomach acid to absorb, break down and absorb B12. So if we have low stomach acid, sublingual B12 can be really helpful. I also want to add on an active B complex because we know we need a lot more B vitamins to support the methylation cycle besides B12 and folate. Magnesium glycinate at night. So remember, magnesium can be calming, but it also is a cofactor in the methylation cycle. So it can help her clear out those estrogens. And then I added on green tea daily. There's a study from 2014 I thought was super interesting, showing that green tea can help with fat metabolism by it helps to reduce food intake. It interrupts lipid emulsification of absorption, so you don't absorb as many fats. It suppresses adipogenesis, so the kind of creation or of fat tissue, and lipid synthesis, and it increases energy expenditure via thermogenesis, so making more heat in your body. fat oxidation, and fecal lipid excretion. So you can excrete more of that fat in your stool. It's pretty cool. And then, of course, the 2 tablespoons ground flaxseed meal daily. So the ground flax seeds will help elevate sex hormone binding globulin, but they can also help with estrogen detox. They can also help add more fiber to the stool, which will help with phase 3 of estrogen detox. Remember, phase 3 is when we get rid of the estrogens, the estrogen metabolites in the bile or the stool and the urine. So, of course, we can give her hormones, we can give her progesterone, we can give her supplements, but we also want to work on regulating her blood sugars. So, it might look like metformin or maybe some supplements with chromium, vanadium, cinnamon, gymnema, berberine, ALA, NAC, and inositol. Those have all been shown to help with blood sugars. Of course, we're going to try to get more protein in, make sure she's not skipping meals. So there's other things we can do for blood sugar besides supplements. Even stress reduction can help with your blood sugars. With the diet, might look at the genetic testing to see some dietary things that we can move around for her. Detox support. So of course, we know that fiber is going to help estrogen detox, the cruciferous veggies, the carrot family veggies, rosemary, all of these help with hormone detoxification. And if we can follow the environmental working group Skin Deep, they have a Skin Deep app to eliminate harmful substances from the skincare products. So environmental working groups, pretty cool. I'm sure a lot of you already have heard of them, but you can go on and you can see like how are your shampoos rated? How is your conditioner rated? What about your household cleaning products? And so you can kind of see, well, if it has a rating of a D or an F, it's probably not good. We want to make sure that we're using products that don't have all these harmful endocrine disrupting chemicals in them, which can affect our hormones. And then movement. So getting more movement in, getting more exercise in. And the MaxGen Labs, that genetic report, can help us understand what type of movement, what type of exercise might be most beneficial for her. All right, so that is it. Thank you so much. If you have any questions at all, you can email us at info@dutchtest.com. I hope this was helpful. Thank you so much for taking some time out of your day to watch this presentation, and we hope you have a great day. Thank you so much for listening.